I'm super excited to welcome back Dr. Merritt today, who we all know by now. And he's going to talk to us today about updates in HIV. And so it's going to be a little different than the COVID updates we've had before, but this is really exciting because we get to talk about HIV and what's new in the field.
I'm going to share a few things that are newer and some hotter topics in HIV currently. I wanted to get started by just talking about where we are in New York City, particularly. And every year, the Department of Health releases the epidemiology, really trying to drill down as we, go on this journey to end the epidemic, which, as we all know, was derailed a little bit by the COVID pandemic, but it seems to be back on track. But basically, the data is always about a year behind. This was just released a month or so ago. So in 2022, there were 1,600 people newly diagnosed with HIV in New York City. 43% of these were Black and 40% were Latino and Hispanic. So 83% people of color. 79% were men, 18% were women, 3 were trans women, and less than 1% were trans men. 49% of those diagnosed overall, so half of that 1,600, and 62% among the men were men who have sex with men. 66%, so 2/3, were diagnosed in the age group of 20 to 39. So that's concerning. But 16% were in the age group 50 or older. And that, one of my favorite sayings is, age is not a condom. We have to keep looking for HIV in all folks who may be at risk, and really speaks to the need for universal testing. 41% of these newly diagnosed people lived in high or very high poverty zip codes at the time of diagnosis. Unfortunately surprising, given the structural issues in our society and structural issues in healthcare, that a lot of preventable and treatable diseases seem to have preference for the poor. Some of the key takeaways from this data was that in addition to newly diagnosed folks, they try to estimate how many new infections there actually were. So we'll see a graph, and depending on how much testing is done, that newly diagnosed number may be higher than what we actually believe to have happened in terms of new infections during that year. They estimate that it was fairly stable compared to 2020 and 2021, which is a little bit disappointing. But again, the pandemic years really, as everyone knows, made access to healthcare, including prevention, more challenging. The progress on improving outcomes has slowed a little bit, which is also disappointing in terms of getting folks linked to care once they're diagnosed within 30 days, which is really the minimum for what we would hope for. The New York State Department of Health really wants us to link folks to care within 4 or 5 days if possible. And then, the goal of starting people immediately on therapy and getting people suppressed within 90 days, those rates are sort of flat. In 2022, 1,603 people died with HIV, and that annual death rate on a sort of percentage basis of folks with HIV, 11.1 per 1,000 people, was a little bit higher than the citywide all-cause death rate. So we still haven't brought those curves together in terms of folks with HIV being at a little bit higher risk of dying. And a pretty large number, 8% of the deaths among people with HIV were due to COVID-19 in 2021. We don't have the 2022 numbers. Obviously, that's dropped. Just to illustrate, where the new diagnoses are coming from, over here on the left, the lighter colors are lower poverty areas. The darker colors are very high poverty. And you can see that the diagnosis rates per 100,000 people in these neighborhoods correlates pretty strongly with poverty rates across the city. Some good news in terms of perinatal infections. This goes all the way back to 1988, where you can see that in red here, there were, hundreds of kids being diagnosed with HIV. At that time, even with the treatments that we had available, there was about a 1 in 3 chance of a child being born with HIV to an HIV-infected mother. Around about 95, 96, the AZT trial showed that AZT was beneficial in protecting folks in terms of perinatal infection. And then, of course, as more effective therapies became available in the late 90s, early 2000s, and we were able to get moms undetectable at the time of birth, the rates dropped dramatically. And you can see here we've had a couple of years, or 2 to 3 years, of 0 infections. And that's really what it should be. We really aim for that. Unfortunately, there have been years where there have been 1 or 2 babies born with HIV, but we've certainly made a tremendous amount of progress during the course of the pandemic. So this is, I was talking about in terms of the estimated incidence of HIV versus how many were diagnosed. There was a bit of a drop during the pandemic just because people weren't getting in and getting tested. So some of these new diagnoses here in in red, maybe sort of catch-up testing. But still, from 2018, there's a trend downwards. And then in terms of estimated annual incident infections, how many new infections are actually occurring, we've dropped pretty significantly since 2018, but flattened out a little bit here in the last year. In terms of estimated incident HIV infections by sex assigned at birth, during that same time period, again, a nice drop, but flattened out a little bit, with the highest numbers being diagnosed in heterosexual men, next in heterosexual female, lower in injection drug users, and lowest in heterosexual males. So a nice drop overall, but still work to do. In terms of the number of new HIV diagnoses among people aged 13 to 29, which is that group where I mentioned, 2/3 of the infections are occurring, again, during that same time frame from 2018 to 2022, Black and Latino Hispanic people consistently experienced the highest number of new HIV diagnoses, for a combined 88% of new diagnoses in this group in age 2022. So although we do see a decrease in all groups, like many of these graphs, when you're looking at health disparities, again, as a result of the structural racism inherent in our society as a whole and in the healthcare system specifically, although we see improvements in all groups, those curves are still quite far apart. And this is a group that we really want to focus on, young men of color, particularly in terms of prevention. Again, I mentioned, this is just a couple of graphs looking at how fast we're able to get folks into care. And that's gone up a little bit to 81%, which is not too bad, but still fairly flat. And in terms of getting folks virally suppressed within 3 months, which is a challenging thing to do in some ways. When we look at our newly diagnosed folks who come into care with us, very often they may be suppressed within 4 months or 6 months. That's a real goal to shoot for, but 53% is pretty good. It shows that we're getting people into care and getting them on therapy. And again, disappointingly a little bit flat in terms of folks that are virally suppressed or have sustained viral suppression, meaning, consistently undetectable during the previous year. But still pretty good numbers. We're up to 88%. We definitely want to get over 90 with that. And then I thought this was interesting. This top graph shows the adjusted death rate for 1,000 people with HIV by both HIV-related illnesses and non-HIV related causes of death. Starting back in 2000, you can see that in terms of all-cause deaths in folks with HIV in 2000, the rate was quite high, 36.5. Remember, now it's 11.1, with the non-HIV folks in New York being around 8%. So 36.5 was quite high. And so we've come down quite a ways to 11.1. Then look at this red line. These are directly HIV-related deaths that in the year 2000, typically from opportunistic infections or failure of therapy, at 24.1 per 1,000. And that's come all the way down to 2.1. And obviously that's a number we'd like to see at 0. And then in terms of non-HIV related causes, it stayed about the same. And then if you look at this little chart down below, it's a little complicated. It looks like a map of the subway a little bit. This is sort of the top 10 non-HIV related causes of death among people with HIV over the last 10 years or so. And if it drops out of the top 10, it's no longer seen. But you can see that cancer stays number 1 or number 2 up to number 3 in 2020. Again, probably pandemic year, lack of diagnoses, but still cancer is one of the top causes of death, not unlike the general population. Cardiovascular disease has remained number 1 or number 2 over that 10-year period. So heart attacks, strokes, accidents. This is also a big cause of death in the general population. Chronic lower respiratory diseases, things like emphysema, COPD, smoking, has stayed in the top 10. And then things like influenza and pneumonia, which, theoretically are preventable and treatable diseases, use of or poisoning by psychoactive substances. So this really speaks to overdoses primarily. And then down here, diabetes, which you can see was number 8, number 9, and now has been going a little bit higher. And so, these are not necessarily all that different from the general population. But what's important to realize about most or all of these is that there are things we can do about them. And again, it starts with education, it starts with outreach, it starts with getting people access to care, it starts with addressing those health disparities that we talked about. But in terms of HIV-related illnesses, making HIV testing just a part of routine healthcare, destigmatizing it in that way, it's just something we do periodically, getting people engaged in HIV care very quickly, as we talked about, and then ongoing engagement and treatment. Certainly at our clinic, we do a lot of work reaching out to folks that maybe haven't showed up for an appointment recently, and we try to keep tracking people down until we determine that they're in care or maybe they moved out of state. We want to make a lot of efforts to keep people in care. In terms of HIV prevention, which I'll talk more about a little bit later, we have oral and injectable methods of prevention. We have undetectable equals untransmittable. So folks that are undetectable on therapy can't transmit the virus through sex. There's always safer sex, condom use. Although prevention is really important, it's interesting that you have to treat or you have to get about 50 folks on HIV prevention, PrEP, to prevent one new infection, whereas keeping 3 patients who have HIV undetectable will prevent one new infection. So in some ways, the bang for the buck is with keeping people who have HIV undetectable, but of course, we really want to be aggressive on both fronts. And then in terms of cancers, cancer screening, again, some of this is access to care, but we do have some very effective ways to screen for cancer, including cervical, prostate, breast, and colon, and lung is one I didn't put on the list, but should have mentioned lung cancer screening for folks with a significant smoking history starting at age 55 with low dose CT scanning. We're really seeing the benefits of that, have picked up some lung cancers, which, if not picked up early, can be devastating. We picked some up very early with those annual cancer screenings. So really paying attention to doing the routine screenings can really make a difference in terms of cancer risk. Better hypertension and diabetes screening and treatment, and then addressing cardiac risk factors, which I will talk about more a little bit too, and something that's pretty new, a new study that came out. But things like smoking cessation or reduction, treating cholesterol, treating diabetes, these are all things that we can work on. And then vaccine acceptance, this is just a partial list of vaccines, but COVID, flu, RSV, measles, varicella, pneumonia vaccines, or other things, meningitis boosters. There's a lot of vaccines these days, and we all have a lot of vaccine fatigue. I think, there are some that are more important than others. They're all important, but, a study just came out a couple of days ago that showed that in the older age group over 75, having not had the most recent COVID vaccination was a significant risk for hospitalization and death. So really keeping up with those vaccinations is important. And then in terms of substance use, there's a lot we can do in terms of just talking to our patients about it, offering treatment, harm reduction strategies, such as access to clean syringes, Narcan distribution, test strips for xylazine and fentanyl that we can give out to folks that are using, better access to substance use treatment, safe injecting sites, of which there are a couple in New York, and have really proven to save lives, as controversial as they may be. Speaking of hotter new topics, this study came out last year, I think, and it was one of the more important studies, I think, that has been done in recent years in HIV. There's always been a feeling that the formulas that we use to sort of estimate someone's cardiovascular risk don't really include HIV as a risk factor. They include things like your total cholesterol, your HDL cholesterol, your age, whether you have diabetes or hypertension. HIV is not a specific risk, but we know that with HIV, there's some degree of what we just call ongoing inflammation generally that does lead to a higher risk of heart disease and other cardiac and cardiovascular events. And so they started this study over 5 years ago, and it was pretty straightforward. They enrolled almost 8,000 people, and you can see it was all around the world: Africa, South America, Southeast Asia, South Asia, and Europe, and a lot of sites in the United States and Central America. So a pretty diverse population. The entry criteria were a little complicated, but basically they took people that we would sort of consider low to moderate risk using our standard ways that we assess people, plugging them into this formula. So in other words, people where we wouldn't necessarily say, gee, we really need to start you on some cholesterol medication. It might be, let's work on diet and lifestyle, and let's try to get the cholesterol down. So a group of folks not really considered at high risk of developing any cardiovascular disease. They all had HIV. They basically randomized them, and about half got this pitavastatin, which is what we call sort of a moderate intensity cholesterol medication, so not super aggressive, and half got placebo. A third were women, and 65% were non-white. And they stopped the study early at 5 years because of the significant difference. Age was about 50. And what they found was that the rate of major heart disease events was actually lowered by 35% for the folks that were taking pitavastatin compared to the placebo. And the incidence rate of major heart disease events or death from any cause was lowered by about 21% in the group taking the pitavastatin, possibly due to other anti-inflammatory effects of the statins. It was effective in both men and in women, and it was well tolerated with pretty few side effects. Just to summarize, in this group of 50-year-old folks, most of them have had fairly high T cell counts. Almost 90% 90% were undetectable in terms of control of their HIV. They stopped it after 5 years. The incidence of new major adverse cardiovascular events like heart attacks and strokes was about 4.8 per 1,000 person years. So 1,000 people over 1 year, you might see 4 events in the group on the treatment, as high as 7 in the group not on the treatment. So this was a significant difference, and they decided to stop the study. Now, one thing I always like to point out is, although this is a significant and dramatic difference, this is a low risk group. And you can see that even though 4 or even 7 per 1,000 person years, the vast majority of patients did not have anything happen to them. And that's to be expected. Most folks were pretty healthy with low risk for cardiovascular events. So the absolute risk overall, the relative risk overall, was lowered, but the absolute risk was still relatively low in both groups. There were very few side effects. So this was just looking at it graphically in terms of the cumulative incidence of events over time. This is 5 years, 6 years, and this was decreased 35% in that group. Where does this leave us? And as I mentioned, not really any significant side effects. It's known that the statin drugs as a class can potentially raise your risk a little bit for diabetes, but this was balanced by the fact that a lot of benefit was seen in those folks with diabetes in terms of protecting them from heart disease. And then in terms of muscle aches and weakness, which is something we always keep an eye out for. In statins, it was a little bit more as expected in the group, but low overall. The United Kingdom actually, after these results, pretty much made a blanket recommendation that folks living with HIV should go on statin therapy, regardless of the risk. And I think we'll probably have some more guidelines coming out. But I think, all of us as providers are focusing a little bit more in that group of patients that typically you'd say, well, your cholesterol's pretty good, you don't smoke, you don't have high blood pressure, let's not push it for now. We're talking a little bit more about it and talking about the results of the study and offering it to patients. And I think it is something that is important. Anyone with diabetes already, we do recommend that they be on a cholesterol lowering medication regardless of what their cholesterol is. But we're starting to look at it in a broader population. Another thing that's not as new, but we've been getting going, Cabenuva, or long-acting cabotegravir and rilpivirine, which are 2 HIV medications. The injectable therapy has now been out for a couple of years. It's logistically a little bit complicated for some clinics to get it going. It's kind of labor intensive, and the shots need to be done on site at the doctor's office. This is one of the many studies that was done over the years where they basically compared the every 2-month dosing of this shot, which is an intramuscular shot of 2 medications. So it's really 2 injections compared to taking Biktarvy, which is probably the most commonly prescribed and effective viral therapy we have now. And they randomized them 2-to-1, twice the amount of people on the injectable, and some people just continued on their pills. Basically, without going into too much detail, it's a relatively young group, mostly male, a fair amount of people of color. The BMI was relatively low, although they had folks that had a BMI over 30 in both arms of the study. And again, the T cells were on the high side. Everyone was undetectable at entry to the study, but there were a small number of people that had lower T cells. And folks had been on Biktarvy for 1 to 2 years. And what they found at the end of month 12 was that in terms of having viral load less than 50, it's pretty equivalent. A little bit higher in Biktarvy, but this is something called an intent to treat analysis where they include everyone. So people who may have dropped out of the study are included in this group. So there was no statistically significant difference. And in fact, in terms of confirmed virologic failure or a couple of viral loads over 200 during the past year, there were only 2 in the injectable arm versus none in the Biktarvy arm. So a little bit higher, but a very, very good success rate. In terms of the folks that did have their viral load come up, but were quite adherent with the injections, what they found was some of them were the mutations that showed that people were resistant to rilpivirine was a risk. And that's not surprising because it's a 2-drug regimen with rilpivirine being one of them. It's very important before starting on injectable therapy to review any previous resistance testing that had been done, even if it was done years ago, and to consider what we call an archive test, which is a test for resistance that you can do on folks that are undetectable. It's a little bit different than the regular resistance testing we do in people who are not undetectable. And none of these tests are perfect, but we want to look for any previous resistance because it would not be a good idea to go on this therapy. Another thing, interestingly, that they found out was that HIV subtypes A1 or A6, and the classification of HIV, there's HIV 1 and 2, and then there's four main groups of HIV 1 that they call M, N, O, and P. M, as in Mary, is the major subgroup, really worldwide, and certainly in the United States. And then within that group M, they subtype even further to A, B, C, D, E, F. And these vary by geography. That subtype A is pretty rare in the United States. They've seen it in folks from the former Soviet Union, but it can happen. We don't routinely test for it, but on archive tests, usually they'll show the subtype. So that's another reason to think about doing an archive test. And in folks that had a higher BMI, overweight, the recommendation is to use a longer needle to make sure that the injection reaches muscle. So that's another important thing that the nurses are trained in. That can be helpful. But overall, very effective. There are some injection site reactions, but it is, as I said, considered pretty equivalent to oral therapy. You can take the medications orally for a month before you start the injections. It's optional, but it could be a good idea if you've never been on these medications just to make sure that you tolerate them okay. Although any allergic reactions are pretty rare to both of these medications. As I mentioned, looking for resistance, using longer needles in folks with a BMI over 30. And injection site reactions are common. People can be a little bit sore for a day or two, but almost everyone sort of says, yeah, I get used to it over time and it's not so bad. And, one of the downsides is that you got to go to the doctor's office to get it. It's 2 shots, 1 in each butt cheek. So that means you're going in every 2 months to get these shots. So it's not for everyone, but it's a good option that we're using more and more. I wanted to talk briefly about cabotegravir, which I just mentioned as one of the drugs that's used for treatment of HIV, but now has been approved alone, just cabotegravir alone, that long-acting injection for the prevention of HIV in both men and women. This particular study was in cisgender men and transgender women, and it was randomized double-blind, so everybody got a shot and a pill, whether it's placebo or not. They were on Truvada, which is the standard oral prevention therapy. They enrolled 4,500 patients about, and again, this was an every 2-week dosing versus daily dosing of the Truvada. And what they were looking for was, how many new infections in each arm. And again, fairly dramatic over time. You can see here in the group taking the oral medication, the risk of developing HIV was significantly higher in the group that was getting the injection medication, and about 1.22 per 100 person years versus 0.41. So very significant difference. However, a lot of that difference, it's important to note, was because of people stopping or missing doses of the oral therapy. We know that the oral therapy taken every day is as effective, most likely, as the injectable. But, that is a reason to consider it. Certainly people who are maybe struggling to be adherent and take that medication every day, thinking about coming into the office every couple of weeks for an injection and not having to worry about taking that pill in terms of prevention could be a powerful way to do better with prevention. This is a similar study that was done in women, and the results look pretty similar, highly effective. So approved for both men and women. Summing up prevention, we have 2 good oral regimens that can be taken daily, and Truvada is approved both for sexual transmission and transmission in injection drug users. Oral Truvada has the option of being used on demand, so you don't have to take it every day. You could take 2 pills prior to a potential exposure, followed by 1 pill every 24 hours for 2 days, the so-called 2-1-1 approach. But that is only approved for cisgender men who have sex with men, and it's not approved in women to be used on demand. We don't know if it's as effective. And then cabotegravir for injection for the prevention of sexual transmission. So a lot of good prevention options. And again, just reinforcing that undetectable equals untransmittable, U equals U. So being on therapy and being undetectable is a very important way to prevent new infections. And then lastly, an even newer topic I wanted to talk about is what we call post-exposure doxycycline to prevent bacterial sexually transmitted infections. And this is something that we're offering now. This study came out last year. It was open label, but randomized, and it was looking at men who have sex with men and transgender women who were either on PrEP or had HIV, and who had had at least 1 bacterial sexually transmitted infection in the past year, so gonorrhea, chlamydia, syphilis primarily. And what they did is they took 500 folks and they again randomized them 2-to-1, either to take doxycycline, 2 pills, 200 milligrams, within 72 hours of condomless sex, months, or to receive standard care, which is to not take the doxycycline, essentially. And they looked at the incidence of diagnoses each quarter during the study. They did STI testing quarterly, and in this study, unlike some earlier studies, doxy could be taken daily if needed, if there were exposures daily, whereas in some of the earlier studies, it was not taken as frequently in those situations. And what they found was a very big difference in overall incidence of new sexually transmitted infections. Standard of care was 31.9% of the time at a quarterly visit in the folks on PrEP, only 10% in the folks doing doxycycline, and a similar difference seen in people with HIV using doxycycline as PrEP. There are some theoretical concerns. It tends to be very, very effective at preventing chlamydia. It's effective against gonorrhea, but a little bit less so, and also effective at preventing syphilis. But there are strains of gonorrhea that are resistant to that class of antibiotic. And in that group of folks who did have infections, they saw a higher, not surprisingly, a higher number of that strain that's resistant to doxycycline. And doxycycline is also an important antibiotic that we use for other things, particularly a resistance Staphylococcus aureus, which is something that can cause severe skin infections. And so we're a little bit concerned we don't want to create more resistance in that group of folks. So, we really want to keep an eye on trends. So as with everything, there's potential downsides, but it certainly seems to be very effective at reducing sexually transmitted infections. About a 55% reduction in gonorrhea, including pharyngeal gonorrhea, gonorrhea in the throat. Against chlamydia, was 88% effective PrEP group and 74% in people living with HIV. And they didn't see a lot of syphilis, but there was definitely a reduction in the doxycycline group, with a trend towards a reduction in the HIV positive group as well. What else is new or potentially on the horizon? Some of you may have heard of lenacapavir, which goes by the brand name Sunlenca, that's been approved. It's exciting because after sort of an initial loading dose, it can be given every 6 months, and it's a subcutaneous under the skin shot. But right now, it's only approved as an additional medication along with other oral medications in patients who have fewer options because of resistant virus. But it's exciting to see a medication that's been developed that's effective just given every 6 months, and we hope to see more of those, or perhaps, studying lenacapavir along with cabotegravir every 2 months, or other combinations of injectable therapies. They're still working on monoclonal antibody combinations that are given by infusion through the IV, similar to what some of you may have gotten or heard about during COVID. They're antibodies designed to specifically attack the HIV virus. And so in folks that have HIV, using combinations of antibody infusions could potentially keep HIV under control for 3 months or 6 months without having to take oral therapy. There's a drug that has not yet been approved, but is being looked at in implants, kind of like the implantable birth control Norplant, where there's a little implant you put under the skin, you load it up with drug, and potentially could work as a HIV preventive for a year or more. The same drug may be able to be dosed every month. They're looking at that in terms of prevention. And then there's newer drugs that are used to treat resistant virus, which fortunately we don't see as much anymore, but one called fostemsavir. So that's kind of, I think, some of the more interesting and newer and important topics going on right now in the HIV world.
Some of this stuff seems to have sort of bottomed out, but there's a lot of good news in here too about, treatments that are available, about trends that are going in other directions. The one that gets me is the bursts of HIV positive, we get down to 0 and 1, and that's pretty amazing to me. Just highlighting the fact that there's a lot of good things in the midst of this too, even if some of those things haven't gone quite in the direction we want them to. And prevention is a real big key there in these treatments as well. So
absolutely,
great to stay up to date about this.
And, really some of the things that we're talking about today in terms of, for instance, using more statins, or really focusing on existing preventive care, treating your hypertension and your diabetes and getting your cancer screenings. People living with HIV are living lives as long and as healthily as people living without HIV. And, there may be a little bit of a tiny gap, but when you see the gap that existed 10, 15, 20 years ago, we've made huge amounts of progress, and there's more progress to be made, but it's encouraging that the numbers are going down. And I do think the pandemic had a big effect, and I think we'll start seeing those numbers go down again.